TATTON study is a phase 1 study looking at the combination of osimertinib, a third-generation EGFR drug, with various other drugs, and I presented the results from the Savolitinib arm. Savolitinib is an oral MET inhibitor. So we looked at this osimertinib-savo combination in a couple of different cohorts of EGFR patients who had acquired resistance to their prior treatments by virtue of MET amplification. So there's one cohort where the MET amplification arose after a first or second generation TKI, and then there's another cohort where the MET amplification arose after a third gen TKI.
No, it's really personalized medicine on steroids. We've already taken EGFR directed therapies, which we've been using for 20 years, and now we're figuring out what to do next, when patients become refractory, which unfortunately everyone does. I've been doing this as long as anyone, and most patients will become resistant to EGFR targeted therapies. We've known for many years now from the work actually from Jeff Engelman and his colleagues and others that c-MET, the receptor, the pathway, is upregulated in patients who become resistant to EGFR targeted therapies. And what we're finding is now that we're using third generation drugs like osimertinib, even more patients seem to be overexpressing that at resistance. So that's nice because when patients become resistant, we now have this new target that we can use. And the savolitinib data actually look quite compelling.
What we saw in the first and second gen progressors who were MET positive is that they had a strong response rate of around 50% to the OC-Savo combination, and the median duration of response was around 7 months. Then in the cohort of patients who progressed while on a third generation drug, the majority of them had already received OC alone as their third generation drug. The combination of OC-Savo also had a nice response rate of around 25% with a median duration of response of 9.7 months. One thing that we know about targeted therapy treatment is that the more lines of treatment or the more targeted therapies patients are exposed to, the more heterogeneous their tumors might be. And so the lower response rate that we saw in the patients who were more heavily pretreated could have to do with the fact that just in general they were more heavily pretreated, maybe a little bit sicker than the patients who were treated in the second line setting on this trial, but also their tumors may have been more heterogeneous. The MET amplification may not have been as focused, and we're certainly going to do some further studies to look at that. But the biologic principle behind the treatment is the same in both groups, that when you have acquired resistance being driven by MET, and then you pair a MET inhibitor and an EGFR inhibitor together, you can see responses.
My sense is that many of the patients, got this drug after they'd already had several targeted therapies, they've already had chemotherapy. I bet the results could be even better if we used it up front, maybe even as the first line resistance therapy, if we're measuring for c-MET, which is now more common, or even think about combining it now with osimertinib in the frontline setting, moving it up. And what we've seen in lung cancer therapy over the years is moving things earlier always works better, because if you have the targets, the patients are fitter, have fewer comorbidities and side effects, and can tolerate the drugs even better. So I think that what we're seeing now is the worst case scenario, and there's clearly activity there.